So I was asked to speak about futuristic models of genetic counseling, and as I was doing some reading and sort of thinking about the topic, I thought that it's worth taking a minute to talk about the past. So a little over 10 years ago, Steve Jobs released the first iPhone, and I gave birth to my twins. And I mention this because, I wasn't an early adopter of the smartphone. I had a regular camera, and whenever I would take pictures of my daughters, I would have to go through what now seems like a very painful process. Like I would, and you all remember this. You would attach the camera to the computer, you would download the photos you wanted, and then you would reattach them to an email and you would send them out. But I still thought it was like the coolest thing at the time to be able to do. And eventually when I got the smartphone, I was like, oh, I get it. Like this is so much easier, right? So is there anyone here who doesn't have a smartphone now? We have one person holding out. I love it. But the reason I mention it is because I think this is kind of how technology works in our everyday lives. Like something gets released and then we're a little bit hesitant and then it just sort of creeps into our lives until we get to a point where we say like, oh, do you remember when we used to have to do X, Y, Z, right? And the older you get, the easier it is to think of what are all those things we used to have to do. And my children actually don't know a world without smartphones, which is pretty incredible to me. And I think we're entering an era now where our smartphones are going to know more about us from a health perspective. They're going to carry more information about us, real-time data about us than our own medical records. And I think that's going to shift the healthcare dynamic a lot. And I think eventually that's going to impact us. And it's already impacting us in some ways. So with that, I want to talk a little bit about the emerging trends in healthcare. And I want to talk about what's happening in genetics now that are maybe on the forefront of those trends. And then when I talk about new models of genetic counseling, maybe they won't seem so outlandish to you. Okay, so I think if we're going to talk about where genetics is moving, we kind of have to look at where is healthcare going, because healthcare, genetics, of course, doesn't occur in a vacuum. And this is an infographic that I obtained from The Economist, and I thought it's just worth looking at, because if you just look at what are the trends on the top, you keep seeing AI, genomics, you see things like hospital redesign, you see that term that we all hate, designer babies, but of course related to designer babies is genetics. And so I think it's pretty fair to say that wherever healthcare is going, genetics, genetic counseling is going there as well. And in some ways, I think we're even leading the way. So here's what else is happening. People are living longer. Virtual health is gaining traction. There's a lot of investments in virtual health. Sequencing costs keep declining to the point where I think it's justifiable to think that genetics is going to be just a routine part of medical care at some point. And then the analysis of digital real-time data through wearables is also gaining traction. So things like wired shirts instead of an electrocardiogram that only looks at data at one point in time. And then I would be remiss to mention the rise of artificial intelligence. I prefer the term augmented intelligence. It's a term that I heard when I was at a precision medicine conference, and I think it speaks more realistically to what AI is. But I actually believe wholeheartedly that AI is going to take us back to practicing patient care with humanity. And I say that because I think so much of what we do as genetic counselors has become administrative. And I'll just give you an example. Like when I worked in a cancer clinic, I would spend hours of my life talking to patients before they even came in to see me, just to see if the referral was an appropriate indication. Because it otherwise would have been a complete waste of their time and my time, and I didn't have that much time to waste. And so that was like a very rudimentary form of triage. But at the time, it was still like the most efficient way to do it. And I think providers don't leave medicine because of patience. I think that burnout is a function of all of the kind of mindless administrative work, the prior authorizations, the billing conversations, like all of the things that we kind of feel like, I didn't think that this was going to take up so much of my time when I decided to become a genetic counselor. And I actually think it's detrimental to the patient-provider relationship because it really takes away from the ability to just like engage with the patient about the issues at hand and have a kind of a meaningful conversation with them. So I'm excited about the potential of AI to take some of these things off of our plates, and I hope that I can instill some of that excitement in you as well. The other thing is that, we can have these really enriching conversations with patients, but we don't have to have them physically in the clinic. And here I think I'm preaching to the choir a little bit, right? Because we have led the way in genetic counseling with telehealth. I think we were among the first to kind of solve this issue of geography being a barrier. I often say, like, the world became flat a long time ago, but medicine is just starting to catch up. And this concept of, we need medicine that kind of mirrors societal preferences. And this concept of large hospital systems that exist in very specific urban areas. I think, I've been doing some reading on the idea that that will disappear in favor of smaller kind of mobile units that are strategically placed throughout the country, whatever country you reside in. And that's going to reduce the disparity between urban healthcare and rural healthcare. And part of that is because so much of what we monitor within hospital and clinic settings can now happen at home. And it's already starting. Like there are ways to monitor the elderly at home so that we don't necessarily have to shift them into a nursing home. And we're also like just looking at, are there other ways that we can communicate information to our physicians, right? So apps that can look at moles that you can send to your dermatologist and have them assess to see if you actually need a biopsy. And I know, like, personally, if I'm really sick, but it's, if it's a routine thing, like let's say I think I need a strep culture. And this happened recently, actually, with my daughter. We just ordered the strep culture kit online, and then we sent it to the pediatrician, and then she called in a prescription, and we never actually physically went in to see her. And I think that, like, for me, that was super cool, but I think that's actually going to become the norm for many routine things. And I think partially it's because we live in a culture where convenience matters a lot to people. People want healthcare to come to them. I don't think this is a bad thing. I love the idea of house call medicine making a comeback. I love the idea of calling an Uber with a physician who can come to your house. And these things are happening. I have a friend who is now working in the Uber health department where they're actually looking at how physicians and providers can dispatch an Uber that's specifically for patients. And as a side note, I was reading that in Nigeria, they have Uber for tailors so that you can have a tailor come to your house instead of having to physically go to the tailor to alter your clothing. So, I mean, it's just becoming a part of the culture, right? And so, you know, I think that this is something that we need to start thinking about and embracing in terms of like how are we practicing genetic counseling. And again, I do think that we're doing it at a much faster pace than other specialties are doing it. Like for example, I know when before I worked at Clear and I worked at a lab, we had on-demand counseling so that if a patient was really anxious about results, they could call in and speak to a genetic counselor. And I think that probably resonates with some of you in this audience as well. So this article was published earlier this year, and it's kind of a projection of where genetic counseling will be in 2030. I think it's worth reading. It's a really interesting article. And one of the things they say is that the practice of genetic counseling is going to be impacted by the public's expectation that things happen basically when they want them to happen. I mean, it's not going to be true for everything, but I think we're going to have to think about making our services more readily available. And I fear that if we don't do that, that we risk becoming less valuable to the health ecosystem, because I think it's starting to happen in other areas of medicine, and we also need to keep up with it. So with that, I will talk a little bit about what's happening in genetics now. Full disclosure, I don't plan to take the full 45 minutes because I think that this lends itself well to discussion, so I really want to open it up to Q&A. So the bottom line here is more and more people are getting sequenced across the world, right? And this is like an example of technology creeping in, like it's starting in the research setting, it's getting to the clinical setting, but we can't possibly talk to all of these patients. So if we want to utilize genomic medicine to its highest potential, we need to start thinking of other models of genetic counseling. And I think this is a diagram that really says a lot. We have very rapid growth in genomics, but the infrastructure has really not kept up. So there's estimates, then this is based on the US, but there are estimates of about 10 new genetic tests a day, thousands of different combinations of panels of testing, and then you have a hospital system, they've got some testing they do in-house, some they do in reference labs, you have some insurance companies that require prior authorization. You have discrepancies between who's offering what to different patients. And then, of course, that's all compounded by very complex workflows and lack of expertise. So I think that if genetics is poised to be the anchor for precision medicine, that we need to fix this. We really need to start thinking about workflow. We need to think about ways to streamline genetics into routine medical care. We need to find ways to scale the same way that genomics is scaling. And so I'm going to go back to the smartphone for a bit because I was reading Dr. Eric Topol's book, The Patient Will See You Now, and he equates the smartphone to the printing press, which he says that it's the most democratizing technology we've had since 1440, which is like a huge statement to make. But then as I was reading, I really started to understand that knowledge in the 1440s, before the printing press, came really from the top down. And the printing press put a lot of knowledge into everyone's hands all at once. And similarly with, the internet and the smartphone, everyone kind of has knowledge at their fingertips. And so this, along with the fact that a lot of medical tests are going to be available through the smartphone, which I'm still grappling with myself. I know, Laura, you mentioned the Minion and the ability to, sequence on a cell phone. These things are happening in the startup world. And so we're getting into kind of a realm of medicine, I think, where you may go into your physician's office, you may go into your genetic counseling office with more information than your provider, and that tips the scales, right? So now there's an equal, maybe, exchange of information, and I think it's going to have to, and I think it's a good thing, shift that sort of pervasive theme of medical paternalism, because there will be so much information, and hopefully it can be more of a dialogue between provider and patient. And I actually think we're pretty good in the genetic counseling field because of how we've been trained about paternalism, but I think paternalism is still a huge factor in the way that patients interact with their providers. So the fact that we're all going to have access to so much information is going to have to change that dynamic, and I think it's for the better. So there's already been a lot of talk about chatbots at this conference, so I don't know that I have to introduce the concept of what a chatbot is. And I do want to, before I talk about this particular chatbot, just disclose that I'm an employee of Clear Genetics and I work on chatbot technology. But this is a combination of the revolution of the smartphone and then the ability to use software to simulate human conversation. And so what you're looking at is a screenshot of GIA, which is an acronym for Genetic Information Assistant. And GIA is a chatbot, and in this particular case is providing, these are just screenshots of pre-test education for carrier screening. So this is kind of like, the non-threatening kind of education that I think we can start using chatbot technology for. It's education that's delivered inconsistently right now. So if you look at the way education for carrier screening is offered throughout the US, it varies from a patient being handed a brochure and being told, here's some information, it's optional, let us know if you want to do it, which is, I think, the worst form of patient education, to here we have some information on our website, you can read about it, it's optional, tell us if you want to do it. To those who actually have the privilege of seeing a genetic counselor before they get carrier screening, but I think that's pretty rare because we're really busy with a lot of other things. And then I've actually had some conversations with nurses who really take it very seriously and go through a little more information about the conditions and what you can do with the information. And it would be lovely if we could train more nurses and physician assistants to do this kind of pre-test counseling. But the reality is that it's really inconsistent across different practices, depending on the amount of time you have with the patient. And I think that doesn't do justice to the patient, and it's not really informed decision making at all. So the idea behind this particular chatbot was to try to use it to educate patients in advance of their appointment, so that before they even go to see their OB, they would have a little bit of knowledge about what carrier screening is. And you can see there are buttons that the patient can press, so there are layers of content, and the patient can kind of navigate based on how much information they want or don't want. And they can also go into detail about what would I do with this information? Why would I want to know this? And also information, questions that they can then send to their provider, so that by the time the provider sees the patient, they can see exactly, how much education the patient actually completed and what questions they had, and then they can use the session to address those questions. And if you think, you can embed a video into the chat as well, but if you think about giving someone a video, which I think is also a nice way to provide consistent education, you have no way of actually tracking if they watched the video. Whereas in a chat, you can actually see how far along they got, which questions, what path they took. So it does give the provider, it's like a two-way exchange. And so I also wanted to show the example that Geisinger Health System is using, because I think that they're really on the forefront of using chatbot technology for their research studies. So they're doing whole exome sequencing, and they're offering it to all of their patients. And if you can imagine, that's too many patients to talk to, right, ahead of time for consent. So they developed a consent chatbot, which basically goes through all of the important aspects of the consent process before the patient actually speaks to the genetic counselor. And so they did a lot of focus groups and actually published the data just came out last week on how patients kind of responded to doing a consent in this manner. And I'll talk a little bit about that. What's interesting is that they developed, and I think this is really where the utility of chatbots is to augment patient care, is that like we have a journey that we want patients to go through, but we can't necessarily be there to follow through on every point along the journey. So one example is family sharing, right? So we all think family sharing is important, especially when it comes to actionable information, but the traditional approach is that you give the patient a form letter or an email with some information, and you really urge them to share this with certain relatives. We don't necessarily know. I was looking at the literature to see like how many patients actually share. It's really hard to track. And it also puts the burden of communication on the proband, who's already dealing with their own, diagnosis or whatever it is that we're talking about. So we have a family sharing tool where the patient can tell their relative, look, I have this information. I'm going to text you a link. When you open that link, you're going to be in a HIPAA-compliant environment, and then Gia is going to talk to you about the results that are specific to our family, and you can ask whatever questions you want. And so we find that patients are more likely to share using this. I think also because it mirrors the way people converse with their family members now. Like most of us are on our phones texting people. I don't remember the last time, excuse me, I mailed someone a letter. So I like that it's kind of mirroring modern communication modalities. And then there's the actual genetic counseling visit. And if they receive one of the ACMG 59 clinically actionable variants and they're told what to do, Gia then reaches out a month later. So it's like a link that they get on their phone or their email. And again, once they open it, they're in a HIPAA-compliant environment. And then Gia collects information on whether they actually followed through with the recommendations, and if not, kind of nudges them to do it. And so this has been like a really interesting journey to help develop with the Geisinger team. And it's all genetic counselors that are working on the various scripts, what we should say, what we shouldn't say, and we analyze the questions that come in, and then we iterate the scripts. And so, unlike a video where once you produce it, if something changes in genetics, you have to kind of redo the whole video, right? But because this is software and it's words, we can easily iterate the script and say, okay, all the patients are asking this particular question. Maybe we need to build that into the education. So this is the publication. I thought I would put it up here in case people are interested in reading it. But essentially, they interviewed patients to get their take on how they felt about engaging with the chat. And this is just one of the quotes that I pulled, but I think it's representative of a lot of the quotes, which is that people felt that they had more time to process the information because they were doing it on their own time. And if it's a long chat, they can actually leave and then it'll resume where they left off. So they don't have to do it all at once. And so it kind of fits into people's lifestyles as well. So I presented some data at ACMG, and I thought I would just touch upon it a little bit. With the carrier screening chat, we actually tested it on 181 women in advance of going into an OB appointment. These were patients who were not pregnant. Because I strongly believe that patients should be getting this information before pregnancy. So the idea was just to see, like, you know, do they engage with it? What do they think about it? Do they understand the information? Does it make it easier for the OB than to just have the conversation about carrier screening? And we did find that patients found it very easy to use. It's pretty intuitive. It's built to be intuitive. Most of them said it was an effective way to get information. There were 1 or 2 people who said that they would rather speak to a genetic counselor. But I think that's a good way to triage, because the people who really want to speak to a genetic counselor, we can, you know, connect them to a genetic counselor. And then we asked, how did this experience make you feel? And we got a range of answers. I think the overwhelming majority of them were positive responses, but you do see some people who say that they were uncomfortable or they were bored. It made me laugh because I'm like, you know, I don't ask patients after I do a counseling session how the experience made them feel. So I'm like, you know, they might be bored when I'm talking to them also. But I think, you know, those emotions, I think, are to be expected. I think I was pleasantly surprised, though, that people felt empowered, you know, because that's what we're looking for. We want them to feel empowered, informed. Grateful was even pleasantly surprising, that they could make a decision that aligns with their personal values. So with that in mind, I want to talk a little bit about what are like some new models of genetic or new-ish, not new. Okay. So one thing I've been thinking about a lot is we're talking about how everyone's going to be sequenced at some point, right? And we're talking about how there's not enough of us to talk to these patients. And so I've been thinking about this model of helping patients make key decisions across a lifespan. So the idea being that, like, everyone has access to whole genome, maybe whole exome, whole genome sequencing at birth, maybe even before birth, depending on how, what direction we go in. But then we only release information at specific points in time. And I kind of took the liberty of making educated guesses on when we would release that information. And of course, there's a lot of other things that go into this, consent and opting in, et cetera. But I think if we think about this model, then genetic counseling moves from an interaction that's limited usually to 1 or 2 times of talking to a patient to having like a lifelong relationship with patients and maybe understanding them from an emotional perspective, how they make decisions, what their values are, and actually being able to lean into those counseling skills a little more than I think we can in a shorter session where we're trying to kind of force feed a lot of information. So if you'll indulge me, I decided, like, well, let me see what we're doing now, for example, for sports screening, because my daughters both play soccer, and they're on a travel soccer league, and they pretty intense soccer players. And I got this form. And I was like, are you kidding me? Like, this form is our way of screening now. And if this form looks like it's from 1976, I'm pretty sure it is. It's been photocopied so many times that it's barely legible. And like, I'm a person who knows something about this, right? But all it asked me to do was sign to say that my child could participate in sports. But this is like a really rudimentary form. This isn't even screening. This is just acknowledging. This to me is like telling women who are pregnant that there's a 3 to 4% chance they could have an outcome with birth defects or any other kind of abnormality, but like, sign here. We're not going to offer you any ultrasounds, any screening. It's just like acknowledging that stuff can happen, right? And I think this is going to change. I hope this changes. I was actually floored. I was like, I have to take a picture of this because no one's going to believe me. But I think this is going to change. I hope this is going to change. And I think as a result of it, our roles are going to change. I think the other significant change that's going to happen is that patients will be able to crowdsource their data, which is particularly important for rare diseases. I watched Diagnosis on the airplane ride on the way here. It's a Netflix show. Has anyone else seen it? And the first case was a genetics case, right? And I was like, this is awesome. If you haven't seen it, you should see it. It's a show about people with rare diseases who basically don't have a diagnosis and then are using putting their information online and using experts and even just average people from around the world to help them figure out what's wrong with them. But I also think what's going to happen as a result of this is that the clinical significance of variants is going to change more rapidly than we're used to. So going back to this article on new kinds of patient interactions, I think there's probably going to have to be this specialty for genetic counselors who kind of keep up with what's going on and can connect patients to clinical trials or can help them just assimilate this information into their lives. Okay, so I couldn't resist putting this quote up here. I'm going to let you read it for a second. This quote is about the printing press in 1440. I mean, the idea that everyone could have information at the tip of their fingers is not new. It's just that the modality is new. We've been here before, but this quote could very well be about genetics and genomics, right? And I think we're facing the same issue. There's so much information. It's outpacing our understanding. And I think that we, as genetic counselors, are going to be invaluable because we are the ones who are going to have to help people differentiate the useful information from the mistruths, if you will. So how do we get there? I thought I would ask a few colleagues. I decided to ask a number of colleagues, but then I realized the themes were the same, so I just chose two quotes to put up here. But from getting from point A to point B, I think one of the themes is that we're going to have to move away from genetics being its own sort of niche specialty clinic, and we're going to have to be part of care teams, where genetics is just a routine part of the evaluation of a patient. And then from our very own president of NSGC, I think the idea that these tools are going to be developed because we need tools to scale. But we need genetic counselors to be involved in the development of those tools so that they actually serve our needs. And I think that's what's going to get us away from the repetitive work that maybe we don't like to do, and get us back to having more meaningful relationships with patients. And if I'm being honest, that's exactly why I decided to jump into the chatbot pot, because I just felt like it was happening and there were no genetic counselors really doing it. And, we can't criticize from afar. We have to get involved and make sure that we help shape things with our expertise. So this is not to say that this is without challenges. I think there are going to be a lot of challenges. All of this, I think, that we've addressed at some point during the past 2 days. And I don't know that I have the answers to all these questions. I'd love to hear what some of your thoughts are. But I do think one of the things we really have to think about is doing all of these things at scale. How do we do that? We're going to need tools to do that. Janine, you'll be happy with this slide. Because you know what I realized? I think this is the article you were referring to yesterday. And as it turns out, I did read it. But I think non-directiveness came from a well-intentioned place. But I just think that it's time for us to be comfortable with being, with providing guidance. We are well equipped to guide patients what to do by reflecting kind of what they communicate their values are. And I've seen this, for example, when I work with surgeons, right? They'll kind of go through all the options that a cancer patient has for surgery, and then the patient will inevitably say, well, what do you think I should do? And I think that's a question that when we're students, we're always told to kind of just reflect back to the patient, right? But the surgeons would always say, well, in my experience, and given your particular situation, and given what you've told me about this and this and this and this, I'm leaning towards this particular option. What do you think, right? And I don't think that's being prescriptive. I don't think that's saying oh, you should do this. And I think we're capable of doing the same thing. So I think that they're going to need our guidance. And I think that we will have an opportunity, and I'm looking forward to it, to being and having more of a counseling relationship with patients, because there will be so much information that they're getting over time. And hopefully we will have more than 1 or 2 chances to interact with patients. And I think that's actually going to make our roles really exciting. So just like, medicine and house call is sort of making a comeback, I think that we're going to go back to our roots. And I think those of us who lean in our conversations more towards the science side of things, we do so because we're crunched for time and we have 1 or 2 times to see a patient and there's so much to discuss. But I think if we have the opportunity to engage with patients long term, we can sort of lean into those counseling skills. And I think if we have the tools to offload some of the repetitive work, then we also have the chance to lean into those counseling skills. So whichever way it goes, I think we're coming from a position of strength. I think it's always good to end on a high note. This is a tweet I think I tweeted last week, and I really was geeking out because I just know, and I'm sure everyone here knows, when even just 10 years ago, nobody knew what a genetic counselor was, right? And now in 6th grade, it's part of the curriculum. And I saw it, and I was like, I have to take a picture of this, and I have to tweet it, because that, to me, just speaks volumes. So with that, I will end, and I am happy to take questions.
Thank you. That was really great. So if people have questions for Shivani related to the presentation, it's open now. And then we've got the panel discussion for a more sort of discursive conversation. So any questions?
Thank you. That was lovely. I wish I had taped it so I could listen to it again. I wanted to ask you about the GIA chatbot, of course.
Sure.
Because what we talked about before, about the ability of having the transcripts available, because that would be a really useful tool in genetic counselling, if you could see what the patients had been asking and how the chatbot had been answering. So I was wondering, how is GIA published? Is she on a secure platform? Is there a log-on? And how do patients use it? Can you say something about that? How did you get past the risk analysis about having all the transcripts available?
Yeah, so we, from the beginning, felt that because we were sharing PHI, that it had to be on a HIPAA-compliant platform. So if you see like a widget on a website, it's different than GIA, and I think the main reason is that GIA, the chatbot, has to come from the physician's office. So the physician deploys GIA to their patients' cell phones when they're scheduling patients. And then once the patient clicks into that link that comes from their physician, they're in a secure environment. And so we can take that transcript and send it back to the physician's office. And we also ask the patients if they would like a transcript as well.
And can I follow up?
Sure.
Do you have any numbers of how much do patients actually use the chatbot?
I do, but I can't remember. I mean, I can tell you that we've had at least 20,000 interactions with the chat, and it's only been a year and a half, you know. And I think we're very also, like, to make the point, because earlier there was the slide comparing the different chats, and I think what we have to keep in mind with these clinical grade chatbots is that we're designing them for very specific use cases. And the genetic counselors are designing, like, what are the more frequently asked questions that come up, and then what are the responses? And they'll specifically say, if this question comes up, the response should be refer to the team. And that varies depending on who we're dealing with. And so we're very careful to make sure that the chat is actually mimicking what the genetic counselors would do in the clinic, and that it's not just kind of like going off on a tangent on its own. And then as we see more questions come in, we can make sure that GIA is capable of answering those questions. And that's the AI and the natural learning processing.
So Selena, we'll take your question, then we'll move to the panel. So thank you.
I was just going to comment on, you thought about this potential future of when patients are coming in with or people come with more data than the physician, and they're approaching, and I wonder, I think often as us as genetic counselors, as being educators, do you think there will be a position whereby we can educate our health professional colleagues to take a more genetic counselling approach to all sorts of interactions? In other words, we're asking the patient what it is that they're looking for from this data, so in effect, the skill of being a genetic counsellor is not limited to genetics. It becomes something that is an approach. Now, I'm kind of reflecting that based on some personal experience, in that I have a voluntary role, that I'm a street pastor once a month, and people may not be familiar with this, but basically we go out and we help people on the streets in the middle of the night once a month. And in the 10 years I've been doing that, policing methods have changed in our city, and apparently that's because the police have seen how effective we are at diffusing situations and helping calm situations and finding, and I just thought, actually, as an analogy, that's quite good, and I don't know what your comment would be to that as a vision that physicians might learn from us about how to approach, or other health professionals learn from our approach. And
wouldn't that be lovely?
Yes.
Yes. why not? I mean, so what we're facing isn't so unique to genetics. I mean, there are a lot of other specialties. We have an ophthalmologist in the crowd here who was telling me yesterday that with some of the tools they have now, that they're also grappling with, like, what is their identity in ophthalmology? Radiologists are facing the same thing. So this is just kind of a shift in medicine that I think, and that's why I say I think it's going to bring us back to practicing medicine with humanity, because I think we're actually going to have a conversation with patients about, okay, well, you know, what is it that you were seeking from this information, and how can we work through this together, and what can we do about it?
Thank you very much.